So Yasmin, we talked about diet and exercise. Now let's talk about medical interventions and what would be the first line of therapy with someone who is interested in primary prevention. And I also would like to remind you to talk about calcium scoring and where does that fit into this pathway?
That is an intertwined question, actually, which I'm sure you know, because intervention, our first line intervention for preventing heart disease does have to do with the cholesterol profile, and it has to do with statin medications. And statin would be like Lipitor, atorvastatin, or Crestor, which is rosuvastatin. Those medications work not only by lowering LDL, the bad cholesterol, but by reducing inflammation. And this is something many people don't understand, or that isn't well distributed in the mainstream media, is that they are not just cholesterol drugs. They also prevent, through many different mechanisms in the body, including the inflammation mechanism, they prevent heart disease in terms of heart attacks and strokes. So people who have risk factors, like if they have high blood pressure, it's automatically recommended by our national guidelines that they get on a statin because their risk of having a heart attack is pretty high. If they have already had a heart attack or a stroke or had a stent put in because they have known coronary artery disease, they should be on a statin. And the doses that they should be on is also recommended differently based on what their underlying risk is. So, somebody might be on 40 or 80 milligrams of atorvastatin versus if they've had a heart attack already versus 10 or 20 if we're just starting out and trying to prevent them early in the process and they haven't had known heart disease yet. And then there are people who have diabetes. They should also be on statins. So basically there is what's called ASCVD risk, atherosclerotic cardiovascular disease, ASCVD risk assessment, that we have a calculator that our American College of Cardiology, American Heart Association has available for us. And if, you put in different parameters like blood pressure, like different parts of the cholesterol profile, age, gender, you put that into the calculator and it will tell you what your risk of having a cardiovascular event, heart attack, coronary artery disease, stroke over the next 10 years is. And if your risk is 7.5% or higher, a statin is recommended. Now, if it's not clear, if maybe your risk is 5%, but you have these other risk factors, you've got the family history, you have obesity, you may have smoked earlier in your life, and it's not really clear, then a coronary calcium score can help decide whether or not you should be on a statin, because it can tell you how much calcium is in your coronary arteries. And that is felt to be a marker of atherosclerosis and what your risk is of having those arteries get clogged and somebody having to go see you, Dr. Marin, because they have, they're going to have clogged arteries. So if your calcium score is 100 or higher, then we generally think of putting you on a statin. The higher it is, and depending on what the coronary scan shows exactly, you may need other interventions. You might need a stress test to determine your risk, especially if you have any symptoms at all, which would be shortness of breath, chest pain, chest pressure, jaw pain, fatigue, some of the signs, that your patients know well. So we put all of that together. But if your coronary calcium score risk is, a coronary calcium score is less than 100, we may say, let's just watch. Let's just keep watching your cholesterol profile. Let's just do our lifestyle changes that we know are good for us, dietary, physical activity. So that's where the coronary calcium score can really help.
So, there's been a lot of press about statin medications. Number one, it increases your hemoglobin A1C, and patients hate the risk of, the muscle pains and aches and delayed tendon healing, things like that. Let's talk about the concept of, your hemoglobin A1C increases because you're on a statin.
And so it does with higher dose statins and with higher potency statins. So there's no doubt about that. There was a trial called the Jupiter trial, a trial of Crestor. And at the higher doses, especially the 40 milligram dose, people who were on the edge of having diabetes, they had prediabetes, it may have tipped them into having diabetes. So I am cautious with those people, and if they are not diabetic yet, I really don't want to push them into diabetes. And so I would use a lower dose of statin, or you could even use the statin every other day, because some of these statins like Lipitor and Crestor have long half-lives and they last 2 or 3 days. And so you might try that. That's another strategy, by the way, for people who say that they have muscle aches on the statins. I've often found if they take it just 2 or 3 times a week, they still get the risk benefit, lowering their risk, lowering their cholesterol, but they don't have the muscle aches. So that's a strategy. For people who don't have heart disease yet and could have torvastatin, which is Lipitor, 10 milligrams or 20 milligrams, I would start that rather than going for the higher dose, because it doesn't have the effect on the hemoglobin A1C, and you can still get a really good LDL lowering, and you get that benefit of lowering heart disease risk with that. Just having a little statin on board, as we call it.
So, I have some patients who come to me and say, hey, my LDL is great, but I don't want to be on a statin. And I tell them exactly that every plaque is covered by a membrane, a thin membrane, and the statin stabilizes the thin membrane so that it doesn't rupture and cause an acute heart attack. And that effect is there even with the low doses of statin. So I'm giving you a statin not because your LDL is too high, but because I want that anti-inflammatory membrane stabilizing effect from the statin medication. So I'm so happy you are bringing that up as well. Now, there's another pesky little problem South Asians, especially people like me from Indian origin, have, which is the low HDL problem. My husband suffers with that, and we are like trying to get. Can you talk about the low HDL in the South Asian population itself?
Yes, and I'm glad you bring that up, because the South Asian population has a higher risk of cardiovascular disease and diabetes, and that really seems to be genetically determined. As you've mentioned, it's not a destiny, though. Genetics are not your destiny. So while you may have a higher risk, you can also lower that risk with what you do with your diet and your lifestyle. It means you just may have to be more vigilant about your diet than other people may need to be. I come from Arab ancestry, and we have the same issue with people from Middle Eastern populations. So South Asians, Middle Eastern populations also have a higher risk of diabetes, and that leads to a higher risk of cardiovascular disease. However, what you mentioned in the South Asians seems to be an independent risk for cardiovascular disease, separate of whether or not someone has diabetes. And the low HDL is also a problem we see in both populations. And we unfortunately have not found a medication that raises HDL and has been shown to lower risk of heart disease. So what I'm saying is we have medicines that raise HDL, but when we've done large clinical trials to see whether or not that makes any difference, it doesn't. Even if we raise it unnaturally with a medication, people are still having the heart attacks. So it's not stopping heart attacks by raising HDL. What does help in those populations is dealing with the other risk factors. Mm-hmm. So basically, forget your HDL number. Don't look at it. Do all the other things that are good for you anyway. Do the plant-based diet, follow the DASH or the Mediterranean diet, get your physical activity, take your statin. That is probably very important if you have other risk factors as well.
And I don't rely on, sometimes they say, oh, if you have a high HDL, that protects you against heart disease. Don't rely on that too much. There are other factors as well. So, HDL is great. It's great if it's high, but otherwise don't worry about it. Just do the things which you can fix. Now, let's go back to statin therapy. I want to talk about coenzyme CoQ10, and how does that help in improving the tolerance for statins?
So in some percentage of people, I would say probably about a third of people, if they are having muscle aches on statins, taking CoQ10 does seem to help them with their muscle aches. It seems to make it go away or make it much more tolerable. And so there is a mechanism of action that CoQ10 has on the muscle fibers and the receptors in muscle cells that helps, just seems to shield them or improve their tolerability to the effects of statins. Now, I think we need to talk also about how much statins really do cause muscle aches or muscle pain. because there is what we call a treatment bias effect. So if people know that they're on a statin and they've heard that it causes muscle aches, they may be more likely to think or feel that they have muscle aches. And we've shown in many studies is that people who are told they're taking, or they don't know, so the study is called a double-blind kind of study. They don't know whether they're on a statin or placebo. The same placebo is like a sugar pill. It's not the real medication. It's just like an empty pill. And so people who are on the placebo have the same number of muscle aches as if they're really taking the statin. So it doesn't seem to be the statin that's actually causing the muscle ache. Having said that, there is a very small percentage of patients, and it is very small. It's like 1 to 3% who have true muscle aches on statins, can't tolerate them or can only tolerate them once a week, or they can only tolerate lower doses, and that's fine. And there's a percentage of those, well, not necessarily of those people, but there's a percentage of people on statins who do have muscle breakdown, and that's called rhabdomyolysis. That's a very serious event, and everyone who's prescribed the statin does need to be aware of that and the symptoms of that, but it's so rare, we almost never see it. I mean, you might see 1 or 2 cases a year in a large hospital system. So we don't consider that to be any significant risk because the benefit of having a statin is so great in terms of lowering your risk of heart disease. And I tell everyone, I take a statin myself. I have a family history of higher cholesterol. And, in spite of what I do with all of my, lifestyle changes and following good, healthy habits, my LDL cholesterol is higher than 100 no matter what I do, because my mother's was and her mother's was, and et cetera. So I take a statin and I feel very comfortable with that. And I've not had problems. I've had thousands of patients take statins who have really not had any problems. But for those who feel that they have the muscle aches, that's fine. I believe them, and they may help with CoQ10 or these other issues. And I always encourage them to talk to their primary care doctors about changing their statin dose. Lower the statin, change the kind of statin. Maybe you change from Crestor to Lipitor or to some other statin. Maybe you only take it 2 or 3 times a week. But whatever you can do to keep the statin on board, it's just really helpful for your heart.
So another issue with the statins is it can cause liver dysfunction. And, this population, they generally tend to have all the components of metabolic syndrome, and fatty liver is also a component of metabolic syndrome, and they can have elevated liver enzymes. What do you think about statins in patients who have non-alcoholic steatohepatitis, NASH, which, or fatty liver? What do you think about that?
Well, it actually helps those patients. It helps their outcomes. It helps prevent them against heart disease, which they are at higher risk for if they have fatty liver. So it's actually recommended for those patients. And what you do, as a doctor, what you do is just check their liver tests before you start the statin, and then keep checking it while they're on the statin.
You talked about rhabdomyolysis in some statin patients and some patients who just cannot tolerate. What would be their alternatives, despite taking high doses of statin medication, or they can't tolerate, or they have rhabdomyolysis and their LDLs are above 100? What do we do for those patients?
Yes. So in those patients who are following a good diet and doing their physical activity, because really we call those lifestyle changes. Okay, let's just call them lifestyle changes. Really, lifestyle changes are always frontline. Like we talked about at the top, even before the statins, you need to do your lifestyle changes. And when you get on a medication, you still need to do your lifestyle changes. Okay. So in addition to those, if you can't tolerate a statin, or for some reason you don't want to take the statin, there are other medications that lower LDL cholesterol. Remember, LDL is the bad cholesterol. You want it to be low, L for low. So there's a medication called Zetia, or ezetimibe is the chemical name for it, and it can lower LDL a little bit. In people, though, who have had heart disease, proven heart disease, they've been to see you, they've had a stent, they've had a heart attack, they are usually going to require more than just Zetia to lower their LDL if they can't take a statin. And that next line is called a PCSK9 inhibitor at this time. Those recommendations may change, by the way. We're seeing a lot more drugs that we could not talk about. That's up to you. But right now, the third line is a PCSK9 inhibitor like Repatha, alirocumab, or evolocumab are the chemical names for those. And those are really effective at lowering LDL. I mean, by at least 50%. They can, slash your LDL in half, and they have been shown to prevent heart attacks and strokes in patients who have that risk.
Now, I've had some patients who are on these medications and the LDL gets too low, gets less than 50. What kind of adjustments do you make, or what is the least tolerable LDL levels you accept.
So did you say less than 50?
Yeah,
Or
50, yeah.
Oh, that's fine. There's no problem there. So, most lipidologists and neurologists will tell you that there is no LDL that's too low in an adult, in a healthy adult. Otherwise, when I say otherwise healthy, I'm not talking about comorbidities. I mean someone who doesn't have a particular neurological abnormality or a liposomal disease, a very rare disease. So in an adult, we have not seen an LDL that's really too low. And most people find it very difficult on our current diets to lower their LDL less than 50 anyway, 50. And so we just don't worry about that. In fact, there have been studies of people in West Africa who naturally have LDLs that are lower than 50, and they have no heart disease in that population. That is a very profound study. And so, I don't worry about LDLs less than 50 at all.
Now let's talk about red yeast rice. And a lot of patients they are statin intolerant. Statin gives them muscle aches and pains, but they consume red yeast rice either in the rice format or in a capsule format. Can you just go over the whole concept of red yeast rice?
So red yeast rice, if it is truly the correct extract, is a statin. Red yeast rice is lovastatin, and I think that the brand name a long time ago was Mevacor for lovastatin. So, so you are taking a statin if you take red yeast rice. I think that some people may feel more comfortable with it because it's more naturally derived. It's not a synthetically prepared statin, but it is in fact where lovastatin comes from. That is red yeast rice. The problem with red yeast rice is that it's not FDA regulated. And so what we have seen is that there are a lot of contaminated versions of red yeast rice. In fact, some that have caused liver failure and other issues. So you have to be really careful with any FDA supplement or nutraceutical that is not FDA regulated. Be very careful about where you get it and how they purify it. So red yeast rice will give you about a 10 to 20% lowering on your LDL cholesterol. And that may be fine for some people. I have not seen that it's any better tolerated, though, in terms of muscle aches than lovastatin, for instance. So this is a mild statin. Lovastatin is traditionally a mild statin. Same thing with red yeast rice.
So the reason I ask is they are intolerant to red yeast, regular statins, but they are completely tolerant to eating the thing. So it's more of the placebo effect of taking a statin versus something else. So, that's why. Now, I also want to bring up omega-3 fatty acids or fish oils. What is the role of fish oil or omega-3 fatty acids, plant-based or animal-based, on the lipid profile?
So omega-3 fatty acids in high doses lower triglycerides. And we talked earlier about how high triglycerides are bad for you. So they have that role. They don't do a lot for LDL. In fact, they might raise it by a couple of points. It's just not much of a measurable effect. And the studies about whether or not what we get in most supplements of omega-3 fatty acids, whether or not those actually prevent heart disease, those studies have been mixed. However, there is a prescription medication called icosapent that is a very high dose, basically a very high dose omega-3 fatty acid. And it has been shown to improve outcomes in people at risk for heart disease. So it prevents heart attacks and strokes in those people, and it lowers their triglycerides, of course. So there's that. Then omega-3 fatty acids from fish, if you get it in your natural diet, that really seems to be the best way that the body absorbs it, rather than, popping capsules or purified versions of it. And fish and fatty fish in particular, like salmon or tuna, seem to be the best sources of it. When you get it from plants, it is not exactly the same omega-3 fatty acid. There's what's called EPA and DHA. There are two different kinds. And so the amount that you get from plants tends not to be as effective as the kind from fish. So there's just that to consider. I think that having all of these different things as part of a healthy, balanced diet, if you really do what we talked about at the top of the hour, if you really try to get all the colors on your plate, and you try to get the 5 to 7 servings of fruits and vegetables, and you try not to eat red meat, and you do these good things for yourself, then you will get enough of these nutrients that you need for your body to stay healthy, rather than having to supplement.
So, I'm truly not a big supplement believer because I honestly want to lead a lifestyle where I don't take a bunch of medications or pills, whether it is prescribed or non-prescribed. Are there any supplements like people can go out to the grocery store or pharmacy and get, which is actually truly going to make a difference in their overall health?
So actually, let's talk about that. Vitamin D technically is a supplement.
Sure.
And if you have vitamin D deficiency, there's a lot of evidence that you should be taking your vitamin D supplement, and you should take the dose that's recommended by your physician. If you don't have vitamin D deficiency, though, you shouldn't be taking it because that may actually cause harm. With multivitamins, there was recently a study showing that multivitamins, like a Centrum multivitamin, a single pill, okay, a single pill that has all of the trace elements that you may not be getting in your regular diet, that may be beneficial. And it may be beneficial in terms of thyroid disease too. A lot of people don't get enough iodine in their diets. And, you know, us cardiologists, we tell people not to eat salt. And so they're not getting iodized. Salt is the major way that people get iodine in their diets in the United States. So if they're not doing that, they really do need to supplement. So things like that you need to get in your body that you're not getting in your natural diet. Those are important. The other thing I would say is probiotics. There are some probiotics that really do help people. They restore the gut microbiome, and we're seeing more and more that these metabolic diseases like diabetes, some of the inflammation we've seen that leads to heart disease, that is connected to the bacteria in our gut too. And that's another discussion in and of itself. But yeah, but some probiotics can also be helpful.
All right. So let's think about a 30 or a 40-year-old person who may or may not have health disease. If you have to give them maybe 5 things that they can take away from this podcast, which can make things which they can implement, what would those 5 things be?
Okay. Number 1, move every day throughout the day. I can't say that enough. Most of us sit all day long. We sit 8, 10, 12, sometimes 16 hours a day, and then we go to sleep. So it's really gotten ridiculous with what we call the sitting epidemic. So number 1, move every day. You don't have to go to the gym, although if you want to, that's great too, because if you do some regular exercise that you love, a sport, dancing, something fun that just gets you moving, you do that every day, you're going to be in better shape. Your heart is going to be in better shape. So that's number 1, move. Number 2, really look at your diet. Really, really look at your diet. Eliminate the processed foods. I can't say that enough. Eat whole foods, eat real food. The food guru Michael Pollan has said that real food doesn't have ingredients. Real food is ingredients. Okay. So if you just keep that in mind, then you will be doing well to avoid the processed foods. So 1, physical activity. 2, avoid processed foods. 3 is actually going to be diet again. And 3 is going to be really look at following the DASH or the Mediterranean diet to guide you, because those are the best diets in the world for preventing heart disease. And they're delicious, and you get to eat all of the colors, and it's tasty and flavorful. So that's 3. Number 4 is actually going to be community. And we haven't talked about the role of depression and loneliness in causing heart disease, but that's really important. And we have a lot of social isolation these days that started even before the pandemic. The pandemic made it worse. But, you know, as we've seen people connecting only over social media and forgetting to actually meet their friends in person, that has caused a problem, and it's a problem in the elderly too. And we know that as we age, we're at higher risk for heart disease anyway. That's just a risk factor. Age is a risk factor we can't do anything about, but we can try to socialize more and stay in touch with our social connections and social support networks. So that would be number 4. And then number 5 is to get at least a yearly checkup and know what your numbers are, know what your cholesterol numbers are, because if you're 30 years old and you may not know that you have something like familial hypercholesterolemia, which is very, very high cholesterol that leads to heart attacks by the age of 40, you won't know that unless you get your cholesterol checked most of the time. So getting those numbers and knowing what your baseline is, knowing what your blood pressure is, okay, and knowing what your weight is, and really following your weight and maintaining a healthy weight for yourself is going to be important going forward.
Dr. Ali, thank you you so much. I had a wonderful time talking to you. And truly, I think it brings me great pleasure that we both are on both sides of the spectrum and we are actually working towards the same problem in our own ways. And our paths could not be more aligned than right where it is right now. So thank you so much. And once again, people can reach you. Tell us ways to reach you.
Yeah, so the best way to reach me is through my website, yasminealimd.com. That's YASMINEALIMD.com. And if you go there, you'll see the Speak for the Heart blog. You'll see a way to sign up for the newsletter. You can get my weekly newsletter for free. And I talk about all these things every week and the different ways you can stay healthy. So just go straight to my website.
Thank you once again. And I look forward to more collaborations with you.
Absolutely. Thank you for this opportunity, Dr. Mara, and I've really enjoyed it.